I would like to introduce myself. My name's Eric. I'm the Creative Marketing Director at Lightfully Behavioral Health. And welcome to today's info session, Strategies for When a Client is Stuck in Outpatient Therapy. And first, if you happen to have any technical issues throughout the session today, I'm going to pop my email into the chat here. Please just send me an email. That'll be the best way to get in touch if you have a technical issue or question. But before we dive into the main presentation, I want to share some quick updates about our services at Lightfully. And if you're not familiar with Lightfully yet, we specialize in primary mental health care services for both adults and adolescents. And adults, we have RTC, PHP, IOP, and virtual programs throughout the state of California. Also, we have for adults a robust virtual program for IOP and PHP that serves anyone anywhere in the state of California. And for adolescents, we have PHP, IOP programming in the Carlsbad area in person. All of our programs are gender inclusive and we welcome clients of all identities. And we really do pride ourselves on making quality mental health care accessible through extensive insurance coverage, high single case agreement rates, and clinical excellence. For those of you who are tuning in today from regions that we don't have brick and mortar locations, for our virtual services, we do have now flexible IOP and flexible PHP scheduling. This is brand new. PHP includes integrated psychiatric services, so we're excited to be leading among the treatment centers with flexible client-centered virtual treatments that delivers the same quality of care as the in-person treatments. We also now provide targeted treatment for schizoaffective disorder, and our approach really tackles the unique combination of mood symptoms and psychosis, empowering individuals to manage symptoms and move forward with a balanced life. Also, for clients who might be hesitant to start at a higher level of care or maybe could take advantage of some holiday downtime, we have what's called our short-term option. And this really offers intensive support across all levels of care, all the way from residential to virtual, starting in just 2-week convenient blocks. It can complement existing outpatient treatment during high stress periods like the holidays, so they can continue coming to outpatient therapy while they're doing the short-term option. If you think that sounds like it might be a good fit for a client of yours, our admissions team is ready to chat. Okay, on to some logistics really quick. For reference, we are recording today's presentation and it'll be available online afterward. And we also will have a pretty beefy Q&A session at the end. So as questions come about throughout the presentation, please go ahead and save those for the tail end to pop them into the chat. Sometimes they can get lost as we go through the session. And it is now my pleasure to introduce Dr. Nicole Siegfried, who's our Chief Clinical Officer at Lightfully Behavioral Health. She brings over 2 decades of experience in mental health treatment, and her expertise spans eating disorders, mental health, and suicide prevention, and has numerous publications and international speaking engagements to her credit. Nicole's unwavering belief in recovery and dedication to helping individuals build lives worth living has really shaped our approach at Lightfully. So without further ado, Nicole, I will hand it over to you.
Thank you so much. All right. Well, I'm really excited to talk to you all today about what to do when your client is stuck in outpatient therapy. I wish I could have made a longer title because I already don't like the implications of my title, which is that somehow the client is stuck. Oftentimes, one of the first ways that we know that we've hit some stagnation or a plateau is when we slip into some labeling of the client. So sometimes what the first sign is that we see some stalling in progress in terms of symptoms. But the other thing that is a telltale sign is when we start saying things like this. He's not motivated. She's resistant. He's doing that for attention. She knows what to do. She's just not doing it. He's borderline. He's narcissistic. She's not ready to get better, or she's not ready to do the work. These are some of the things that we see in our levels of care because our clients are at higher levels of care. We'll say things like, oh, they're just here for the apartments, or they shouldn't have been admitted. And so when we start saying some things like this, where we're labeling clients or pathologizing clients, that may be a sign of a plateau or stagnation. Here's the other one though. We either go back and forth between pathologizing the client or internalizing. So we say it this way: I don't know what I'm doing. I should have caught that sooner. I'm wasting their time. I'm not doing enough. Maybe I'm not any good at this. They need a more experienced therapist. If I admit I'm struggling, people will think I'm incompetent. And so when we start to fall into these narratives, this can be a telltale sign of stagnation in treatment. And one of the things that's important as part of this is that I had a supervisor once say to me that in marital therapy that when we are doing marital therapy work, that the problem isn't the one spouse or the other spouse or one partner or the other partner. The problem is between them. And when we think of that as something in the therapeutic relationship, is the problem is between, it's not me, it's not you, it's the problem. And so how can we address it in that way? And that neutralizes things, and it allows us to view things through a compassionate lens. So, those of you who have been to some of my trainings before or have been to some of Lightfully presentations, you know about our precision care model. So, our precision care model is, I like to say, powered by process-based therapy. Process-based therapy is the most recent iteration of cognitive behavioral therapies or evidence-based modalities in which symptom drivers are identified, isolated, and focused on as part of treatment. In that focus, we utilize specific interventions in a strategic way to target those drivers. So when we get stuck in treatment, the precision care model is something we fall back on. So when we're talking about drivers, we're talking about what's underneath the iceberg. Those of you who are therapists, I don't mean this in a psychodynamic way in terms of unconscious conflicts or repressed memories. What I mean is that we see the symptoms on the surface, but there are patterns, difficulties, cycles that are driving those symptoms. Symptoms serve a function, they serve a purpose. We need to understand these from that compassionate lens for us to be able to really target those and make progress. So, when we talk about clients getting stuck, we're talking about things like this: no motivation, they're not ready, they're resistant. We can add those to quote symptoms on the surface of the iceberg. And so when we look at this, we can start to wonder, what is it that's driving this lack of motivation? Is it low self-compassion? Is it emotion dysregulation? Is it over-identification with maladaptive schemas or negative schemas? What is it that is perpetuating this cycle? So here at Lightfully, we there's many different drivers. You can see a list of drivers here, possible drivers. There's dozens. We've bucketed them for simplicity purposes. So our buckets consist of difficulties with thoughts, difficulties with behaviors, difficulties with emotions, and difficulties with relationships. So when we're looking at symptoms on the surface, we can start to think, what are those drivers that are pushing into those symptoms to cause a spike or to decrease progress? There are a few different ways that you can assess for drivers. We utilize validated assessments. So we're using symptom checklists on the top of the iceberg to get at depression, anxiety, um, psychosis, distress, PTSD, but we're also utilizing assessments on the bottom of the iceberg to get at those difficulties with thoughts. So we use the self-compassion scale, Neff's self-compassion scale. We use Young's schema inventory in that bucket. We use an acceptance and commitment therapy values inventory with behaviors. We use the DERS with difficulties with emotions and the AAQ in that bucket. And then with relationships, we use Joiner's interpersonal needs questionnaire. You may not use these in your practice. You don't have to use these in your practice. There are other ways to get at these negative drivers. I'll review those in a minute. Let me show you before I review some ways to get at drivers. Let me show you what one of our dashboards looks like. So with our clients, when they come into treatment, they complete a series of assessments that gives us these results in the symptom checklist bucket and then in each of the driver buckets. We're going to dig into this in a moment with a sample client. But you may not have these at your fingertips, or you may not be utilizing these assessments. So we've also developed a series of questions to get at each of these drivers. So these are things that you're going to be looking for in terms of client statements that may indicate that these are the drivers that they are struggling with. So I can't handle my emotions. It feels too painful to feel things. I feel numb all the time. I can't feel my body. I don't want to connect to my body. My emotions are out of control. Difficulties with behaviors. These may be some of the things they're saying. I have no control over my ex. I can't leave the house. I can't get out of bed. I feel like I'm doing things that aren't who I am. I can't stop X. No matter how I try, I can't make myself do Y. Difficulties with thoughts. I hate myself. I feel shame. I don't deserve X. I do deserve Y. I'm bad. I'm too much. It's my fault. Difficulties with relationships. I need others to take care of me. I have no support in my life. No one understands me. Everyone leaves me. I can't be vulnerable with anyone. We have a series of questions that we also, I'll make available in the chat at the end to get at each of these drivers. What's important is as in therapy, as part of these drivers, you're going to select interventions that match the drivers, not the symptoms. So we have a series of 13 integrated interventions. We didn't come up with these. These were developed by Hayes and Hoffman after they analyzed over 55,000 different studies. They gleaned the effective ingredients across all evidence-based modalities: DBT, CBT, ACT, cognitive processing therapy, EMDR, exposure and response prevention. There's hundreds of evidence-based modalities. They gleaned the effective ingredients from those modalities, and they are listed here in this outer orbit. So we select interventions as part of treatment that target the client-specific drivers. So you can see how these match up to each bucket. So if my client is having difficulties with thoughts, we're going to be using interventions like modification of negative core beliefs, mindfulness, self-compassion. If they have difficulties with behaviors, these are the techniques or interventions that we'll use, and so on. So I briefly want to take us through an example client who was with us recently, who is a good example of someone who got stuck in treatment. So this is Russell. Some identifying information has been changed. He's a 39-year-old Caucasian cisgender male. He has a diagnosis of schizoaffective disorder. He presented at our PHP level of care with mistrust, relationship conflict, disorganization, and medication noncompliance. And when he stepped down to IOP, he began missing appointments, he stagnated in terms of progress, and we were stuck. So let's first look at Russell when he admitted to our program. He scored in the moderate range. So we have all these symptom checklists on this side. He scored in the moderate range for psychosis, mild for depression and anxiety, PTSD likely, moderate distress. We see in this red zone his difficulties with thoughts. The areas that are red is low self-compassion. We see another red zone in difficulties with behaviors. Some of these cool blue zones, we always want to look at these because they can also serve as positive drivers or strengths, if you will. And so he scored in the blue zone in terms of relationships, which is somewhat suspect because he was having relationship conflict in his life. But this is something that, if indeed this is the case, can serve as a buffer. He did have a strong support system. So, what we'd started with Russell, based on these two red zones, we'd started with interventions targeted toward values. You notice that his values include accountability, commitment, perseverance, and he feels misaligned with those values. So, we started work there. And then we also utilized interventions around self compassion, mindfulness, and modification of some of these negative core beliefs as related to insufficient self-control, unrelenting standards. Ugh, that's always associated with low self-compassion. My standards are, too high. Perfectionism kinds of things. And then we target progress over week by week. So we just have some questions that we ask each week. These are questions that you can use as part of your practice to monitor each of those buckets. So I'm able to regulate emotions is a proxy for the emotion bucket. I'm able to view myself in my life through a lens of self-compassion is a proxy for the thoughts buckets. My actions match my values, a proxy for the behavior bucket. My relationships have healthy communication, a proxy for the relationship bucket. And then we do a standard measure of distress. So, what we saw with Russell is that he made some progress early on and began taking his medications as prescribed. He was engaged in treatment. We saw distress decrease. And then he stepped down to IOP. And we saw a blip in his progress. So, we first started noticing some things around medication. So he started having some blips around taking his medication as prescribed. We also noticed some blips in attendance. He wasn't attending sessions as much. So this was a warning sign. This is also around the same time that in supervision sessions, we started seeing the team say things like, Russell is just fatigued. He has treatment fatigue. He's been here too long. He probably just needs to go to outpatient. Or he's just not motivated. He knows what to do. He did it in PHP, but he doesn't know now, he's just not doing it in IOP. So this became signals. And I have no judgment around that, by the way. We are human, and this is our tendency to start to say some of those things in supervision that pop up when there is a lack of progress or stagnation. So these are not things to feel bad about. It's just things to explore. So what we looked at when we started seeing this happen was the therapeutic alliance. So, what we noticed is that the client, that we asked this question each week too, how they would rate the client, the overall relationship I have with my therapist. I just took a little snapshot of what this looks like that they do each week. But look at this. When we were in PHP, the therapist relationship was strong. And then as we started going to IOP, we were in the red zone. What we also noticed during this time is that Russell was disengaged. So he started saying, I'm not, my likelihood of staying in treatment now is decreasing and following the recommendations of my team. So we could have just looked at these things and this could have been where we stopped. But we also looked at what was happening in those drivers that he'd identified early on as being the drivers behind his symptoms in the first place. Well, what if those drivers are popping back up in IOP? Well, sure enough, we started seeing a dip in his values alignment. We also saw a dip in his self compassion. So our interventions matched this for Russell. The first thing we did was that we recommended a step back up to PHP. This was a difficult conversation with Russell because he has unrelenting standards. He also is perseverant as one of his values. And so he did look at this as a reflection on him as a person. So we really needed to use some of the language that is, I think, really important when we're talking about when things aren't working in treatment. It may be that you just need to change the dose of treatment. And we decreased the dose too soon. And so we need to increase that dose again and come back up to PHP for a bit. So he stepped back up for 2 weeks to PHP. And with this conversation of this is not a reflection on your character, you just need a higher dose of treatment. Sometimes we'll use this in an analogy that we would use in medical situations where we'd say, you know, if someone were in cancer treatment, we wouldn't say, oh gosh, now you need chemo. The radiation isn't working and now you need chemo. We wouldn't be like, well, you really failed. You know, we talk about it as a failure of the treatment, not a failure of the person. So we really dug into the therapeutic work around, or the work around the therapeutic relationship, because something happened when he stepped down to IOP that really damaged the relationship. So we looked back at some of those schemas. His were enmeshment, insufficient self-control, and unrelenting standards, and looked at where some of these schemas had originated. He is 39 years old. He had 39 years of evidence that he'd used to build those schemas. And he was using old relationships to through the lens of current relationships, or as his lens for current relationships. So some of these were playing out in his relationship with the therapist. So we did a lot of rupture and repair work with Russell. And then we were doing a lot of family work. Family was also getting really frustrated. They were scared. And so they were getting frustrated as he stopped taking medications again and as he became more suspicious. And so we did more family work to boost their compassion and help each side see things through the other person's lens. We also came back to some of that values work. His top three values are accountability, commitment, and perseverance. And as he stopped taking medications, it really pushed up against his accountability button. And so he set up an accountability partner to help with his medications while he was in our apartments. And then we also did more work around self-compassion from really instituting a self-compassion practice, sort of thinking of it as like a gratitude practice or a yoga practice. And with this, he was able to then step back down to IOP and continue progress rather than blipping back down in terms of stagnation. And then had a successful discharge and a successful step down to outpatient therapy. So, in summary, our clients often get stuck in treatment. Our tendency when this happens is to pathologize, it's them, or internalize, it's me. These can be some of the signs that there's stagnation. The precision care model is designed to treat underlying drivers of symptoms. And so, utilizing the precision care model in these situations can be really powerful. We can look at drivers that target, or we can target drivers that may be contributing to symptoms such as lack of motivation, quote, or stagnation. So, looking at symptom drivers and the therapeutic relationship in those situations is key to get us back on track and to help our clients make progress.
Now we'll take 30 full minutes to do a Q&A. For those of you who have questions, please feel free to pop them in the chat. I did get one via email that I want to pop in the chat here for us to start off with. It was, what is one small thing or a shift that a therapist can make in their next session with a stuck client that often leads to meaningful movement?
The first thing is your own self-compassion practice. So I think when a client is stuck, we often are going into the session of what can I do to make them change? What can I do to make them change? The first thing I would do in sessions like that is to come in, ground myself with my own self-compassion, sort of my own motto. Mine is always, you are loved. And when I can ground myself with that, then I am more likely to be able to see this as the problem between us rather than the problem, the client being the problem. When I do that, so like that one small shift is it's a more therapeutic process approach. I'm able to look at this like what's happening in the relationship between us rather than your depression is worse this week. So it allows that step back to see things in a broader way. But it starts with me, not them.
Thank you. We have a question here from Christy. Thank you. How can I gain client buy-in regarding using the assessments before session in an outpatient setting?
This is one of my favorite questions. We have so much difficulty getting clients, especially a lot of them are you have depression, and so it's hard to get myself to do anything when I'm in that mode if I'm speaking for as a client. And so one of the things that we found is the most powerful is to actually use the assessment. So if you're in session, if you're asking a client to take assessments and you never reference them, they're not going to think they're important. So one of the things that we do is if a client hasn't completed their weekly outcomes, we'll say, let's take a minute in session now and do it together. Or I'm going to give you 5 minutes to do it so then we can go over it together. And so that sets the stage of this being, the place where we start session each time. But if you're doing something where you're monitoring it and you're bringing it into your notes afterward, but you're not really going over it with the client, it's going to fall flat. Oh, can I share the slide on drivers? I sure can. This one. Yeah, these are things that they will say. And I'm going to also include in the chat questions that you can ask that get at these drivers.
Okay. We have another question from Rachel here. Do you have any tips or considerations for working with clients who have ADHD where motivation is biologically compromised? Impulsivity can interfere with adoption of coping skills and where insight work can be limited due to hyperactive speech patterns.
Oh, such a good question. And you could fill in the blank with any quote disorder in this situation in terms of ADHD, depression, mania, psychosis, where the actual symptoms of the diagnosis. I keep saying diagnosis in quotes because as a field, we're really trying to move away from a diagnostic framework and looking more at processes of change or processes or drivers. So, but in any of those situations, you can have biological contributors. It's not as important to me as to if it's biologic, like psychosis is a good example too. If it's biologically based, if it's personality based, if it's behavioral, the origin of it isn't as important. Although sometimes medication can be helpful for some of those more biological underpinnings. So that could be one intervention. I still think, regardless of the symptom and its origin, you can start to look at the drivers behind it. So if I have ADHD, it it might be biological, so to speak, that I have trouble with attention or I have trouble with hyperactivity that's interfering. But it's also my conceptualization of what that means about me. So I may have, if I've had ADHD my whole life, I may have learned skills of how to do this. So I need to make sure I write things down. I need to make sure that I take breaks. And I'm not doing those things. So what's keeping me from doing those things? It's not my biological underpinnings of ADHD. It's my drivers. It's that I feel like I don't have it could be low self-efficacy, that I think there's something wrong with me, so that I don't think that what I do makes a difference. It's me, I'm the problem. So those kinds of things, regardless of the origin of the symptom, biological, behavioral, personality, you can still look at the driver that's keeping the client stuck. So that's a beautiful way, one of the ways drivers are so helpful.
There's one more here that we got. How can therapists differentiate between a temporary dip in progress and a true treatment stall that needs intervention?
Oh, that's good. If it's something is like a week, when in outpatient, you're going to have a much longer range of data points if you've been seeing the client for a long time. So when you see just a couple of weeks of stall or a blip or dip, as you said, then that does not concern me. But when you see a pattern, then I think that is something, so a longer than a couple of weeks. Um, might indicate, times, let's look at the therapeutic relationship. Let's look at some of these drivers. I also think that if you're talking about assessments each time, when you start the session, you'll be able to say, we've had a blip for the last couple of weeks. Let's talk about what that is related to. And is this a sign that you're moving more into sort of a red zone, depending on how you talk about things with your clients, but maybe it more into like a orange zone, yellow zone in terms of relapse risk. Even with a blip, I think you can interpret the data. Those of you who are trained in motivational interviewing, I find this the most helpful way to talk about data, because data are just data. And so you don't have to interpret the data for them. The client can interpret the data, and you can have a very neutral approach. What does this mean to you? I noticed last week you were a 5 on this, and this week you were a 3. What does that mean to you? And so the client might say, it means nothing. I've been under so much stress. I've had final exams. This is what happens, or the client might say, oh gosh, this is what starts to happen. It just seems like it's a little blip, but this is, I've been in an argument with my roommate, and this is reflective of what happened the last time I stalled out.
Okay, I do have a couple more here.
Oh, I
That
love it.
got sent in via email. This is great. How can therapists collaborate with programs like a PHP or IOP to ensure continuity of care without client feeling like they've failed outpatient therapy?
I keep saying this, y'all's questions are so good, but I do love these questions. So good. So, first of all, the conversation around needing a higher level of care, I want to say it never goes well. So again, going into those conversations, whatever your motto is, you could go into the conversation with that. But reminding them of this is not an indicator of failure. This is an indicator of needing a higher dose. That conversation, you can use language around that. Also, this is a really good time to use schema work if you've used this and say, how does this rub up against that negative core belief in terms of your unrelenting standards of, I need to be perfect. I need to do things one and done. And so, one of the most important things that we can do in terms of ensure that PHP IOP, for example, is going to be a good decision is to ensure that continuity of care. So there's a couple of ways that we do this with outpatient therapists. When clients are at the IOP level of care, we often encourage them to continue to see their outpatient therapist. Depending on their insurance, they're often able to do both at the same time. And it starts to, especially if they're going to be in IOP for like a short-term stay that we were talking about before, this allows them to keep that continuity. Or when they step down to IOP, maybe if they're staying a longer time with us, that they can start to see their outpatient therapist while they're still with us in the last couple of weeks of treatment with us. That provides a really warm handoff in that continuity. And then, of course, our therapists and the outpatient therapist has to be in good contact. Um, Often, what we'll see is when there's not that good contact, especially when there's stagnation, the client may reach out to the outpatient therapist and say, "This is terrible. It's not working." And so it's important for us to have that collaboration to be able to say, "Hey, we have hit a lull, we have hit a blip, and this is how we're addressing it so that we're aligned." I think we often try to pathologize clients that are splitting or triangulating, and we'll pathologize that. And I think in these times, especially if we look at something in terms of a blip or a lag or stagnation, they're going to resort to those old behaviors that worked for them in other times in their life where things weren't going well. So we should expect it. We shouldn't pathologize it of, well, there they go again. This is so borderline of them to split, triangulate. Instead, we should expect it to say, this is an old pattern that served you well in times in your life, um, that then later blocked your connection. So, of course, you're doing this now. Of course, that's your tendency. And it may even provide some relief, but it may not be what gets what you want in relationship in the long run.
Another question from Christy. Thank you for these juicy questions. If you're able to identify drivers, address them with interventions, and still find they may be stuck, what would the next steps be? Like assessing level of care or reassessing drivers?
When this is happening in sessions with my clients, like I'm constantly analyzing, like I'm looking at the therapeutic relationship, I'm looking at drivers, I'm looking at, is this the right level of care? I'm looking at, is the client on the right medication if that's something that they're using? So you can have sort of your go-to dance moves, if you will, in your therapeutic process. But if you do all of those things and you still feel stuck, and you've looked at the therapeutic relationship and it's strong, then that may be an indicator that a higher level of care is necessary. Because in referring up, one thing I'm always looking at is I don't want the client to start to internalize a lack of progress as part of their incompetence or their lack of self-worth, I should say. And so that's one of those things that just gets me, that breaks my heart of like when clients are thinking, I'm not getting better and it's because of me versus I'm not getting better, but I'm not taking the right dose of treatment. So we never, when if the Advil isn't cutting it, we're not like, oh, it's all because of me. I don't have good pain receptors. I don't know. We don't say those things. We say, oh, maybe I should take a leave, or Tylenol or something. So we I don't want the client to get to the point where they've internalized the lack of progress as an inherent failure on their part. So that's the thing that makes me want to refer up sometimes sooner rather than later, or ride the stagnation too long.
One last question here. If you could offer clinicians or therapists one guiding mantra for supporting clients who feel stuck, what would it be? It might be something you've already said.
Gosh, I feel like I have a lot. One of the most powerful things that we can do is provide a space for compassion and have them feel known and seen and cared for. And so when I feel stuck, I kind of come back to those basics. If the most powerful thing that we can do is be in relationship with the client, not our fancy techniques, not our fancy skills. So I come back to that basic when I feel stuck. So maybe that, I don't know if that's one motto. That feels like it was a diatribe, but but that still could be helpful.
Excellent. And just really quick, to thank everyone for joining us and for engaging in the chat. It was wonderful. The recording will be available by the end of next week, to reference back, and we'll send out the slides. I also want to remind everybody, we Lightfully does work with all commercial insurances, and here are some of our in-network partners as well, and some of our contact information if you'd like to get in touch. Feel free to take a screenshot of this. But the last thing I want to mention is just a really heartfelt testimonial that we got recently. And I'm just going to read this out loud before we say goodbye. This program was instrumental in my healing journey. I was apprehensive to start because I had never done anything like this before, and I didn't know what to expect. It turned out to be the best thing I've ever done for myself. I created friendships with the group members and bonds with the therapist. I felt incredibly supported and safe to be open and vulnerable. I don't know how I could have come out of my depression without the care of this program. Excellent. Well, again, thank you everybody for coming today. We appreciate you. And if you have any further questions, feel free to email or reach out. We are here.
Thanks, everybody.